بسم الله الرحمن الرحيم. في البداية بنتقدم بخالص الشكر والتقدير لأسرة الجمعية المصرية للشعب الهوائية والأخ الفاضل الأستاذ الدكتور طارق صفوت والأستاذ الدكتور عادل خطاب والأستاذ الدكتور أشرف مذكور وعماد قراعة وأسرة الجمعية كلهم على دعوتهم الكريمة والتنظيم الجيد للمؤتمر. ويسعدنا نبدأ وقائع الجلسة ويشرفنا وجودي مع الأستاذ الدكتور محمد صدقي والأستاذ الدكتور ألفت الشناوي الفيرست سبيكر دكتورة منى منصور. She will speak about management of different pulmonary diseases at home.
بسم الله الرحمن الرحيم. Mr. Chairman, professors and colleagues, actually it's a good chance to meet my colleagues and professors, and it's a good chance to thank all the members of Society of Bronchology for their effort. Congratulations for the success and best wishes always for good luck. Bismillah ar-Rahman ar-Rahim. My talk is about the management of different pulmonary diseases at home. I do believe that the importance of this subject and that this idea is beginning to be attracted to the practice. There is two factors behind this. Chronic diseases are increasing, and chronic patients and sufferers are increasing in number, and their stay at hospital longer time becomes sometimes impossible and very costly. And so this idea begins to be in practice in order to get a chance and give an occasion for those sufferers from chronic diseases to be at home in ease, taking their medications in a good way, and avoid this large cost which was paid at hospitals. I'll go to the past sometime, many years before. In 2003, when the British Thoracic Society began to find that this hospital-to-home management or at-home management, it considered it as a safe and effective way to manage acute exacerbations of COPD. And they found or suggested that 1 out of 4 cases presented with acute exacerbation of COPD are eligible to be managed at home. And then in 2004, the society found that they can consider the cases which are managed to some time at hospital and then early discharged to be managed at home in combination or in addition to the cases which were avoided from the beginning to be admitted and managed at home, cases with hospital at home. And that's the term which I'll discuss today. Actually, it was a difficult task to collect all the data which are responsive or under that head. But I have tried to be because of short of time, giving highlight to all the points I will need to talk about. Hospital at home is a specific subtype of intermediate care. Treatment is provided in patients' home for a condition that may require hospital care for a limited period. As I have said, either the patients whom they didn't visit the hospital from the beginning, or those who were admitted to hospital and then completed their treatment after an early discharge at home. What are the conditions needing hospital at home? COPD, bronchial asthma, obstructive sleep apnea, home medical oxygen therapy, and home ventilation. والexamples دي ليست للحظ، دي مجرد examples. After researches and trials and many studies, the British Society have found that they have to put some recommendations for those cases whom we will refer to home and will not keep at hospital. But there are some investigations should be done in order to avoid problems at home. So they advised these recommendations. Sputum culture is not recommended except for patients at hospital with purulent sputum. As we know, all COPD patients have colonization, many colonizations, and these colonizations make the sputum culture not representative to the causal organism of the disease. ECG not performed except if heart rate is less than 60 per minute or more than 120, or if the patient had severe chest pain. Pulse oximetry is mandatory at home. You have to get the pulse oximetry at home if you repair patient to home to be treated. If saturation is less or equal to 90%, we had to do arterial blood gas measurement before referral to the patient, X-ray is mandatory before referral patient at home. Why? Because the findings in X-ray can deviate our management completely. If you find pneumothorax or pneumonias or pulmonary edema, if the patient is cardiac and misdiagnosed as COPD, as this is common, those patients couldn't be or cannot be referred home to take their treatment. Baseline spirometry is mandatory also because of the same idea that the patient should be good or full or truly diagnosed as COPD. Because if he is not COPD and he is treated like that, it will be a cause of great falls at home. كل التحفظات دي عشان at home ما نلاقيش مفاجآت during the treatment. What is the treatment plan proposed by the British Thoracic Society? We give to the patients at home short-acting beta agonist and anticholinergic by nebulizers. Corticosteroids are advised except if contraindicated, like the diabetics. Oxygen therapy is given, aiming to get the saturation more than 90 and meanly less than 94 saturation. Respiratory failure after exacerbation. All of us, we know that sometimes during exacerbation, oxygen is decreasing. But after treatment, most of the patients get their normal oxygenation. If this oxygen is still decreased, we have to consider long-term oxygen after treatment of exacerbation. We have also to put in plan quitting smoking and pulmonary rehabilitation in the form of respiratory exercises and physiotherapy, etc. We can give antibiotics also if there is purulent sputum. We give the empirical antibiotics, but if we suspect an unusual pathogen, we have to tailor antibiotics. So to give antibiotics according to what we expect from different microorganisms. But there are certain situations from the beginning we can say, no, we will not admit the patient, we will not refer him at home. He should be kept at hospital to treat the acute exacerbations. If there is impaired level of consciousness, acute confusion, pH is less than 7.35. If there is changes in X-ray, as we have said before. If there is any concomitant or comorbid medical problem, like diabetes or cardiac state, which is not controlled, we have to stay at hospital. Insufficient social support, and it's very important about that subject, is that the community and the caregivers and the relatives are very important in this relation and the success of referring patient at home and taking treatment at home. So if there is no sufficient social support, المريض وحيد عايش لوحده وده بنقابله كتير in our practice. If there is no telephone مكان نائي أو بعيد عن communication, or the residence is away from the hospital, if there is a problem we cannot transport the patient easily at a time to hospital. And if there is hypoxemia, less or equal to 90% grade, and there is no oxygen, so we haven't to refer the patient at that situation to home. What are the patients we are expecting from the beginning? واحنا بناخد الهيستوري واحنا بنعمل examination that those patients are not candid from the beginning to that, to refer to home. The increasing age, longer duration of COPD patients, when there is frequency of exacerbations all the time, he is getting many times during the year. If there is severe impairment of forced expiratory volume per 1 second, chronic mucus hypersecretion, if there is a comorbidity, cardiac disease and not controlled and not well treated, or generalized debility and malnutrition of the patients. Some patients are in need of oxygen therapy. What are those patients? We are in need of oxygen supplementation. If the arterial oxygen is from 55 millimeter mercury or less, at rest, or if it is between 56 to 59 with evidence of comorbid conditions like pulmonary hypertension or chronic anemia. If there is exertional hypoxemia, if nocturnal hypoxemia, saturation is decreasing during sleep less than 90%. In severe asthmatic attacks, you are indeed to give oxygen sometimes. Cardiac disorders like intractable angina and recurrent episodic pulmonary edema, and in terminal sometimes malignancy, we can consider oxygen. Absolute contraindications, patients who are smoking still at home. It's a disaster. It can cause a disaster at home. What are the types of oxygen source you are depending upon? Now the technology has done a very great task. What is that task? They are providing those patients with very small instruments and equipments, helping them to manage their life with oxygen therapy at home. Oxygen concentrator, as we know, becomes smaller. There are portable oxygen concentrators, but they are providing the pulse doses of oxygen, so we cannot use with it CPAP or the BiPAP. The portable oxygen cylinders, like the E-type, I have found that the cylinders ليهم طريقة في التنظيم. نحن نعرف according the volumes of the cylinders, either alphabetical A to E, from the smaller to the bigger, or we can say M, and in addition to the M, the number of the volume inside the cylinder. And the oxygen conserving devices, which are اللي هم دول وصلات اللي بين السورس وبين البيشنت, like the nasal cannulas. All of this is available now. Small equipments, light to use and portable. They have helped really to let this hospital at home be practical وattract it لأرض الواقع. Now we shift to the asthma. Very rapidly I go through. Asthma measures should be in the form of assessment and monitoring at home. Education is important for a partnership and sometimes for the relatives in asthma care. Teach all patients how to monitor signs and symptoms of deterioration. Respiratory increase rate is increasing, using of the muscles in the neck. Monitor lung functions. Peak expiratory flow rate is something objective to use it, and you have to stress upon. If you send the patient to be treated at home, better to use the peak expiratory flow rate to assess, or flow meter, to assess the severity and response to treatment. And now we are giving the patient a written asthma action plan. having 3 color zones: green, yellow, and red. That can help the patient to talk to his doctor, to tell him and to evaluate himself, his state. And this green for well-controlled zone, and poorly developed yellow, for poorly developed yellow, and very poorly developed the red. تشمل symptoms, the nightline awakenings, the effect on daily activities, the relief of inhaler and the number of the use of these inhalers as quick relief by the patient, and the lung test reading by the peak flow meter. If it's more than 80% of predicted personal best, it's well controlled. If it is from 60 to 80% of predicted personal best, it's yellow. And if it is less than 60%, it's red. It's very easy for the patient to assess his state. Now we are jumping to another state at home, which is home mechanical ventilation. Home mechanical ventilations can be invasive and can be non-invasive. What are the goals of home mechanical ventilation? It can extend the duration of life. It can enhance the quality of life, becomes better. Reducing morbidity, improve the physiological function of the lungs and of the patient in general. Achieving normal growth if they are children and development. Reducing the overall health care costs. Actually, the patients who are in need of mechanical ventilation, invasive or non-invasives, they are very costly and expensive, their stay at hospital. It can manage in this way and decreasing the cost. What are the indications? One, to shift and to jump to that step, which is very serious and important. It may be for his life, all his life. So indications and taking this step is very important. Indications is for the disorders of the respiratory pump. We're beginning from outside, from the chest wall and the neuromuscular and the muscles. Patients with Guillain-Barré, with neuromuscular diseases, obstructive diseases of the airway, parenchymal lung diseases, like cystic fibrosis, disorders of control of respiration, and the cases of central hypoventilation syndrome. Inability to wean, and you are faced with this all the days, every day in our practice, in the ICU or respiratory ICU, that the patients are difficult to be weaned. Sometimes for some time they are in need of this help and with this aid. It may be after prolonged ventilation for a chronic disease. Progressive chronic respiratory failure, sleep disturbance, central or obstructive apnea or hypopnea. There are also some indications criteria in the form of forced vital capacity whenever it's less than 50% of the predicted, or the maximum inspiratory pressure is less than 60, or whenever there is hypoxia with increasing carbon dioxide more than 45, or moderate to severe sleep apnea. Now, what are the contraindications to non-invasive ventilation? As we know, non-invasive needs masks. We see now in some figures and some pictures, those masks are irritating the face and the nose. Sometimes some patients cannot withstand. So in cases of facial trauma or burns, or any recent facial or upper airway or upper gastrointestinal tract surgery, we cannot give this help or this non-invasive ventilation. In case of fixed obstruction of the airway, life-threatening, severe hypoxemia, we cannot depend upon the non-invasive because there is always some leak. Never we give very high oxygenation. In severe comorbidity and impaired consciousness, if the patient have vomiting, if there is copious respiratory secretions, or focal consolidations of the chest radiograph, all of these states we cannot give or help the patient by the non-invasive ventilation. And from the contraindications, we can expect the complications. It can cause facial and nasal pressure injury and sores. So we have to balance this strap tension we are doing to the masks in order to avoid the leak. And sometimes to cover the vulnerable areas with protective dressing to minimize the pressure by the intermediate application of non-invasive application masks. It causes gastric distension. And to avoid this, or to limit it, we increase the peak expiratory pressure to less than 25 centimeter water. We may put a nasogastric tube, but it can worsen the leaks which is present from the mask. However, it can also cause bypassing the lower esophageal sphincter and Purbett's reflux. It can cause dryness of the mucous membranes and sick secretions, humidification for devices, and daily oral care. I'll finish on. There are certain complications which is shared between the invasive and the non-invasive, like barotrauma, hypotension, immediately, and we are expert with this. Whenever we put the patient and connect to the mechanical ventilation, sometimes hypotension occurs, mostly it's reversible, sometimes it's not. Complications avoided by non-invasive ventilation. Non-invasive can avoid some complications caused by the invasive mechanical ventilation, like ventilator-associated pneumonia, sinusitis, or the reduction of sedative agents. What are the factors? I go very rapidly. Factors associated with success or failure. Non-invasive, there is a very good prediction for success. If you put the patient on the non-invasive, after 1 hour, if the pH and PaCO2 respiratory rate is responsive and improving, this is a very good prediction for success. Failure, there are many failure predictions. High Apache score, pneumonias, edentulous aspirations, poor nutritional status, and confusion or impaired consciousness. Those are non-invasive interfaces. Some examples for them. This is the nasal mask and prongs which are preferred by some patients to avoid the full mask on the face. This is the full mask. What of very important, the full mask advantage is that it decreases its leak, but increasing risk of aspiration with that mask and with all the erosions and the affections of the face. This is the lip seal mouthpiece. It's put around the lips with this mouthpiece, and so avoiding all the affections of the full mask. Those are the small ventilators which are portable, used by the patients now, helping them to manage their life. I'll go rapidly through the invasive ventilator because Professor Dr. Magdi will speak about it in details. We are giving CPAP or BiPAP, preferred the BiPAP to CPAP because BiPAP we are giving inspiratory pressure higher than the expiratory. CPAP is not for increasing oxygenation. It's better in sleep apnea. It helps to keep the airways open. We can give pressure versus volume. Pressure is better to control oxygenation than ventilation, and better for younger and non-compliant lungs, while volume control is better for ventilation than oxygenation, and better for older, more compliant lungs. We can give pressure support or inspiration, اللي هو الدفعة الأولى, to help the patients to take their inspiration. About the discharge criteria, it's very important to say that hospital at home is in need of group and team worker, hoping that in the future we can get a group of worker or organization help to supply those suffering and those chronic patients at home with nursing, with instruments, with equipment. It should be under a consultation, under the supervision of a consultant with the junior staff, helping those patients with physiotherapists. As we see, we know that the complications which can be the ventilator failure, tracheostomy problems, the mask-related issues, as we have said, and the under or over ventilation. The outcomes depended on underlying disease. Over 70% to 10-year survival, most deaths due to underlying disease. But 0 to 8% of deaths were ventilator or technology related. some of those patients at home can need hospitalization. But however, the quality of life is better, fewer hospitalization in most of them, better sleep quality, better daytime functioning, some stress for patients and caregivers. As a matter of fact, caregivers and the relatives are under stress. Home ventilation is a reality now in most of the countries outside or abroad, hoping that it becomes a reality here also in Egypt in the future. Every patient is unique. All what we have said are guidelines and not rules. Various settings, interfaces, strategies to achieve goals of good health and optimize quality of life. Team approach, as I have said, is very necessary. Thank you.
Thank you, Professor Mona, about this excellent presentation. Dr. Mukhtar له comment.
لازم يبقى في اورجانيزيشن بالرغم انها بتشتغل معايا في الاسم اللي مش عارفه ان في اورجانيزيشن اوريدي. احنا عاملين شعبه من الرعايه التنفسيه المنزليه، والجمعيه دي شعبه ما حبيتش اعمل جمعيه جديده، واوريدي احنا بنوفر يعني نوبيلايزرز، اوكسجينيتور، سي بابس، ادويه. في واحده ست فاضله عامله شقه في عين شمس، وبنحاول نجمع دكاتره وممرضات وجنرال براكتيشنرز وفيزيوثيرابيست ويلفوا على الناس في بيوتهم. فانا باخدها تشانس اي واحد يقدر يكونتريبيوت باي حاجه او بهيز ايفورت للشعبه التنفسيه المنزليه. ويلكم. ثانك يو.
Thank you, Professor Mukhtar Madkour. Now I would like to introduce second speaker, Professor Iman Jalal, who talked about respiratory therapy equipment.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairperson. First of all, I would like to thank the organizing committee of the 13th Regional Annual Assembly Meeting of the Egyptian Society of Bronchology, Professor Tariq Safwat, Professor Adel Khattab, Professor Yasser Mustafa, and Professor Ahmad Qura'a, and last but not least, Professor Ashraf Madkour for their kind invitation. To start with, the choice of the title of my presentation was based upon the fact that many chest patients might require or candidates for home respiratory therapy, in which they might require several respiratory equipments for the management of their condition. But unfortunately, many chest patients, as well as a sizable number of pulmonologists, are unaware about these equipments as regards their indications, their settings, and the monitoring of such devices. For this, the presentation will be offered. The agenda of my presentation will cover the following equipments, including the oxygen devices, the nebulizer, the portable suction system, the positive airway pressure therapy for obstructive sleep apnea, the portable sleep diagnostics. While the last items, which is home ventilation, will not be covered during this presentation because Professor Magdi Khalil will cover in the coming presentation. The first question to be addressed: what's the target population? Which group of patients might benefit from these respiratory equipments? Actually, patients with airway obstruction secondary to COPD, bronchial asthma, as well as patients with cystic fibrosis, patients with obstructive sleep apnea, as well as immunocompromised patients, including patients with HIV, are the candidates for such equipments. The first equipment to start with is the nebulizer. Simply the invention of the nebulizer in the year 1858, it has changed a lot in the management of patients with obstructive airway diseases. Although this equipment is based upon a simple rationale, which is the conversion of a fluid that can be either a solution or a suspension into droplets through which the patient will inhale the medication. This modality of treatment is indicated majorly in patients who cannot coordinate their inspiratory effort. And in patients targeting this modality of treatment, patients with asthma, COPD, patients with cystic fibrosis, and patients with HIV. So what makes nebulizers at home superior in some condition to the handheld inhalers? When is nebulizer superior? Three major conditions in which the nebulizer will be more beneficial for such patients. If we are in need for large doses of drugs, especially bronchodilators, then nebulizer will be the modality of choice in comparison to the inhalers. And if my patient has difficult coordination, such as patients with acute severe asthma or patients with exacerbation of chronic obstructive pulmonary disease, the pediatric group and sometimes in the geriatric group, this modality of treatment will be of choice. Additionally, some drugs are not available in the form of an inhaler, but alternatively they can be nebulized with a nebulizer, such as the nebulized antibiotics. In this line, so nebulizer will be my equipment of choice. How can I judge my nebulizer? The 4 cornerstones for getting a good system or a good nebulizer system are fast rate of nebulization with a minimum waste of aerosol drug after the completing of the session, the low residual volume, and the distribution of the droplets along the airway is uniform. If I fulfill these 4 criteria, then my working system will be an optimal nebulizer. So what are the available commercial nebulizers present? There are 3 main types of nebulizer present in the market. 2 are widely known, and the last one is less commonly known among the Egyptian population. First, we have the pneumatic nebulizer or the pneumatic jet nebulizer. This device has a basic rationale in which it has a compressed gas, which it can be either air or an oxygen or a compressor that can drive a flow, and this flow can generate an aerosol. This aerosol will deliver the medication for the patient. The volume of these devices can be variable. Sometimes they have a small volume devices or a large volumes one. The second type of nebulizers are the mesh nebulizers, less commonly known in the Egyptian market. Mesh nebulizers are based on the fact that there is a mesh or a plate with multiple apertures. These apertures can either cause a vibration or are static to produce the aerosol droplets. The apertures have a different size which taper toward the side of the patient to produce the directed aerosol in the output channel of the patient. The mesh nebulizer are dependent mainly upon the characteristics of the fluid nebulized, because if we can use the large droplets, it can be impacted in this fenestration, and this modality can sometimes be inappropriate with some aerosol therapy. The last type of nebulizers commonly known especially in hospitals and sometimes at home is the ultrasonic nebulizer. It differs from the jet nebulizer rationale in that it converts the electrical activity into high-frequency ultrasonic waves, which will drive the aerosol droplets. So if we want to compare between the jet nebulizer and the ultrasonic nebulizer, if your patient asks you which of which is better, you have to know the advantages versus the disadvantages of these 2 devices. The jet nebulizer is the nebulizer that's cheap, widely available in the market, but the problem is that it's noisy. Although it has an advantage that it can use the compressed air to drive the medication, which can be beneficial in some patients, such as in acute asthma. While the ultrasonic nebulizer, it's quite expensive, liable for some technical and electrical problems, but it has a large output. The output of the nebulizers, ultrasonic nebulizer, might reach up to 1 milliliter per minute. They can drive a large volume of drug doses, and moreover, this type of equipment can be used with patients who require silence and do not want to be disturbed, especially during sleep. Maybe the most accepted guideline published regarding the use of nebulizer was that published by the European Respiratory Society in 2001. In this guideline, it's important to mention that they identified the most commonly used drugs to be nebulized with a nebulizer. As we can see here, the drugs can be either bronchodilators, including the beta-2 agonist or the anticholinergic, the inhaled corticosteroids, some antibiotics, including the amikacin, the tobramycin, and the gentamicin, and the colomycin, and some antifungals such as the amphotericin B, inhalation of pentamidine, such as in patients with HIV for prophylaxis and treatment of pneumocystis carinii, and in patients with cystic fibrosis, the use of recombinant danase to liquefy the mucus. Another important issue in this guideline is that it identified the dispersion of the drug site for nebulized material. This depends upon the size of the particle. When the particle is between 1 to 5, less than 5 millimeter, then it is commonly dispersed to the peripheral airways, the terminal airways. Whereas if the droplet size may be 5 or more, then it will be blocked in the central airways. What general points do we have to take into consideration while using a nebulizer or prescribing this equipment for our patients? When my patient is having an acute severe asthma or having an asthmatic attack, it's preferable to drive this aerosol therapy with using an oxygen so that we will get a double benefit, the delivery of the drug as well as the bronchodilator effect of oxygen. You can combine several types of medications in the nebulizer chamber. You can combine bronchodilators and sometimes corticosteroids with no effect on the potency of both drugs. Using the nebulizer can be done either with a mask or a mouthpiece. But when do we prefer which of which? As regard the efficacy, both are effective, but the target group can sometimes judge which one will be superior. In children and in old age group, and sometimes in patients with emergency, it's preferred to use a mask. But sometimes we might prefer a mouthpiece, especially when we don't want the nebulized medication to reach the eyes and the skin, such as in cases of inhaled anticholinergics and steroids, as well as antibiotics. It's better if I'm planning to tell my patient to take a nebulizer session to get it away from meals, unless my patient is distressed, so give him the nebulizer session in order to let him eat peacefully. Using a nebulizer is hampered by many caution. Why should you take into consideration that there are some important aspects about this modality, although simple, but sometimes there are important points to be considered. The nebulized dilution solution should be an 0.9 sodium chloride. Never ever to use water as dilution because it will induce bronchospasm. And while nebulizing patients with COPD, especially hypercapnic type 2 respiratory failure, please be cautious while using oxygen as a driving pressure. As we have said that nebulized anticholinergics can induce or can exacerbate glaucoma, so the mouthpiece will be preferred. And as nebulized medications do not contain a preservative, so they must be prepared immediately before the nebulizing session. Secondly, we come to the oxygen therapy, the home long-term oxygen therapy decision-making. When do we decide to make our patients stuck to the long-term oxygen therapy? This is based upon 3 main steps. First, we have to identify what's the cause for hypoxemia for my patient, identify the disease that caused this chronic hypoxemia, so as to treat any reversible factor besides using this long-term oxygen therapy. Second, my patient should be stable for at least 5 weeks, because in patients with exacerbation of chronic obstructive pulmonary disease, sometimes the patient might be in need for short bursts of oxygen, after which we might discontinue. But if my patient is stable for 5 weeks and still he is having hypoxia, then it's indicated to use this modality of treatment. And last but not least, to measure the arterial blood gases for the patient as a baseline, not just to estimate the oxygen, but for other parameters such as the pH and the partial pressure of carbon dioxide. When using oxygen, it's not just based upon the opinion of the treating physician, but there are guidelines that identify when to use as an absolute indication, as a relative indication. This is based mainly upon 3 main factors: the partial pressure of oxygen, the saturation, as well as the presence or absence of any modifying factor. So if the partial pressure of oxygen is less than or equal to 55 millimeter mercury with a saturation of less than or equal to 88%, then this is an absolute indication for long-term oxygen therapy. While if the range is between 55 and 59 for partial pressure of oxygen and 89% or more for the oxygen saturation, then this is a relative indication, provided that there is other modifying factor, including the presence of pulmonary hypertension, the cor pulmonaire, and polycythemia with a hematocrit of more than 55%. So do patients having a partial pressure of oxygen of more than or equal 60 or a saturation of more than or equal to 90 are devoid of using such modality? No, they can use this modality, but upon 2 indications. If the patients experience nocturnal desaturation, or despite being on PAP therapy, on positive airway pressure therapy, then oxygen is indicated. Also, if the patient is experiencing dyspnea that is responding only to oxygen and this dyspnea is caused by a lung disease, then still this is an indication for using oxygen in this condition. To start long-term oxygen therapy, we have 4 main steps to consider: the initiation, the administration, the stationary, and the ambulatory oxygen. As for the initiation, we have said previously that we are in need for an arterial blood gases. And this arterial blood gases, after a period of stability, never to use the oximetry for starting long-term oxygen therapy, because this will not provide any idea about the baseline pH and partial pressure of carbon dioxide for the patient. But alternatively, the pulse oximetry can be used in the follow-up sessions for the patient, not just for the initiation. As for the administration, long-term oxygen therapy should be administered continuously of at least 15 hours a day, including the sleeping hour, and should have ambulatory probabilities, especially for patients who are ambulant. The stationary oxygen can be offered either by a concentrator or by an oxygen cylinder, while the ambulatory oxygen should have certain criteria concerning the weight and the delivering oxygen. It should be less than 10 pounds not to be heavy for the patient to carry for delivering 2 liters of oxygen for a period of 4 to 6 hours. Although in the market nowadays there are some versions that are slightly a bit heavier but provide oxygen for a more prolonged duration of time with a relatively high flow than 2 liters. After deciding to use this long-term oxygen therapy, you have to select what interface to be used in this condition. This is simply depending upon several factors. First, the disease process of the patient. Secondly, the baseline arterial blood gases of the patient. And third, the inherent characteristic of the interface you are going to use, taking into consideration that in patient with type 2 respiratory failure, the Venturi mask followed by the nasal cannula are preferable, while in type 1 respiratory failure, the face mask followed by the nasal cannula are preferable. So, if you prescribe oxygen for the patient, do you have to tell the patient that some certain hazards he should take care of? Definitely yes, because these hazards can sometimes be life-threatening. Although several hazards can occur for patients using long-term oxygen therapy, but most importantly is the fire and the explosion. So please, when you prescribe oxygen therapy for your patient, do not forget to tell your patient not to smoke while using the oxygen therapy, which is a common fault that causes morbidities and burns for the patient. Although some complications might occur such as the atelectasis and the carbon dioxide retention, which is chiefly related to the hypoxic effect of the pulmonary vasoconstriction rather than the direct effect of oxygen. As for oxygen toxicity, it's rare to occur at home because it requires high level of fraction of inspired oxygen, which is mostly not offered at home. The next device or equipment to be used at home is the positive airway pressure therapy or the PAP therapy. What's the rationale for using this device? In patients with obstructive sleep apnea, the relaxation of the upper airway dilator muscle might lead to the creation of a negative subatmospheric pressure. This ultimately leads to the closure of the airways or the blockage of the airways and occurrence of anapneas and the hypopneas. So what does the CPAP or the PAP therapy do for such patients? It simply acts as a pneumatic splint. It provides stability for the airway, allowing the passage of air during inspiration and expiration. When I prescribe PAP therapy for the patient, I must tell the patient the benefit for using such device. Not many patients will be happy to use this device each night of their life. So if you introduce to your patient, if you motivate your patient by the benefits for using this device, you might gain compliance for these equipments. So why do we use these devices? Sometimes we say to the patient that we use these devices because it will relieve you first, and it will relieve your physician next. It will relieve you because it will resolve the obstructive sleep apnea symptoms and signs, the excessive daytime sleepiness, the fragmented sleep, the daytime fatigue, the headache, and the nocturia, and the choking. But what's most important, that it will decrease the possibility of the long-term complications of obstructive sleep apnea, including the cardiovascular, the neurological, and the occurrence of diabetes mellitus and several complications. It will increase your productivity, and it will decrease definitely the incidence for motor car accident, which is very common in such patients. So by motivating your patient, you will gain the accepted tolerance. So what options of PEP therapy are available for those patients with obstructive sleep apnea? This basically depends upon the pressure delivered. So if the continuous pressure delivered is the same during the night, inspiration and expiration is the same, then this is the CPAP. What if the pressure is automatically driven or automatically determined based upon changes in the airways, then this is the APAP. But if the inspiratory pressure is increased than the expiratory pressure, then this is the BPAP, or the bilevel positive airway pressure. And the last device in this category is the ESSB, or the adaptive servoventilation, which offers pressure support for the patient depending upon the rate of his ventilation. So what are the indication versus the contraindication of PEP therapy? When do we prescribe and when not to prescribe these medications? The PEP therapy is the first line of treatment for patients with moderate to severe obstructive sleep apnea. No doubt, it's the first line. But for patients with mild sleep apnea, are they candidates for such modality of treatment? Yes, but on two conditions. If they have 2 or more comorbidities, and in addition, if they are symptomatic. But if my patient is having 1 or no comorbidity, or is asymptomatic, it's not the modality of choice for such patient. What about the contraindication? When it is contraindicated? In place when there is an indication for PEP therapy, there is no absolute contraindication, except on one condition. If the patient is having a correctable surgical deformity, then this can be a contraindication for the device until doing the surgical correction and re-evaluating your patient. Other contraindications are rather relative. What's the superiority, or is there a superiority for the APAP, or the automatic positive airway pressure therapy, and the BPAP, or the bilevel positive airway pressure therapy, over CPAP? As regards the tolerability and the effectiveness, there is no superiority of one over the other. So what affects the advantage of one modality over the other? In BiPAP, it's important to say that it will be superior for CPAP on 3 conditions. The first condition, if your patient is in need for high pressure, 15 centimeter water or more, then he is candidate for BiPAP, not for the CPAP. Or in patients with COPD and patients with obesity hypoventilation syndrome, in which the patient cannot exhale against high expiratory pressure, BPAP will be the option superior than CPAP. As for the APAP, no superiority for the tolerability and the effectiveness, but sometimes it's preferred for the patient, especially if the patients if the patients will need to review with their physicians the memory indulged in the machine, which will provide the follow-up for such device. As for the ESSB, the concept of this ESSB is simple. It provides a target, which is 90% of the ventilation of the patient, minute ventilation of the patient. It provides this target, but once the ventilation decreases, it increases the pressure support, and vice versa. As we can see here, when the ventilation of the patient increases, it increases the pressure support, and the contrary when the ventilation of the patient increases. It's indicated mainly in patients with central sleep apnea and patients with heart failure. The selection of the PAP interface is dependent upon the breathing pattern of the patient. If the airflow is predominantly nasal, then use a nasal or a direct nasal interface. But if the patient is mouth breather, use the full face interface to avoid the leakage. Do PAP therapy have problems? The problems with PAP therapy are minor. And it's important to tell your patient that all problems, including the interface, the nasal, and the flow problems, are minor, and they are reversible, and they are self-limiting. So this cannot hamper the use of such modality of treatment. Can we diagnose patients with obstructive sleep apnea at home? This guideline was offered to address this question. Definitely we can use this, but with the following indication. It's performed only in conjunction with comprehensive sleep evaluation by the physician. Also, in patients with high probability of moderate to severe obstructive sleep apnea clinically and demographically, and in whom he cannot perform this as an in-lab. But when it is contraindicated, when suspecting other sleep disorder, or in patients with significant comorbidity, it's contraindicated to do a home diagnostic for obstructive sleep apnea. The basic sensor to accept a study at home should be three: airflow, respiratory effort, and the monitoring of the oxygenation. As regard the last 3 slides for the portable home suction, suctioning for patients at home has several indications and contraindications. So what about when do we suction our patients at home? If we see visible secretions, or if my patient is on home ventilation with increased peak pressure or a decrease in the tidal volume, or if you suspect that there is aspiration for the patient, or if there is desaturation that's related to the mucus plugging, then it's indicated to suction your patient. So what's the contraindication? When suctioning your patient is indicated, there is no absolute contraindication for suction, but do not do it routinely. It should be based on indication. We should precede this by a step of pre-oxygenation or hyperinflation, administering oxygen with an ambu bag, which is only indicated in patients who experience oxygen desaturation or arrhythmia or on continuous supplemental oxygen. But it is not indicated if the patient has adequate muscle strength and in patients who are in need only for nasal or oropharyngeal suctioning. And please remember that suctioning can cause some complications that might lead up to cardiac arrest for the patient. So revise your indication before suctioning your patient. Finally, to provide a successful home therapy equipment, this should be based on the equation of success, which is the combination of the correct patient selection diagnosis, the correct device, the correct setting, and follow up your patient. Thank you.
بسم الله والصلاة والسلام على أشرف خلق الله سيدنا محمد بن عبد الله. First of all, I would like to thank Professor Tarek Safat, Professor Adel Khattab, Professor Yasser Mustafa, and Professor Imad Urraa, Professor Ashraf Madkour, and all senior and junior colleagues who worked hard and shared in the assist in the success of this marvelous Congress. Second, I would like to appreciate the organizer who designed the logo of the booklet of the conference. As all of us see, it seems that all the patients asking the help of Allah and seeking the advice of the Egyptian Society of Oncology to solve their problems. Last but not least, I would like to thank Dr. Iman for her elegant presentation. It's a very, very nice presentation. And we call last speaker Professor Magdi Khalil, Professor of Pulmonology in Shams University. And he will speak about the domiciliary mechanical ventilation. And I think that all of us will enjoy with him.
Bismillahirrahmanirrahim. Thanks for the organizing committee for inviting me for this talk. Thank you, Dr. Alfat, for the introduction. Thank you for the whole panel. I hope I'll be short to enjoy the coffee break after such two heavy meals by Dr. Iman and by Dr. Aman. I'll speak about home mechanical ventilation with the exclusion of obstructive sleep apnea. Evolution and revolution. The prescription and institution or the continuation of mechanical ventilation at home is increasing rapidly, progressively, but it is not a recent trend or an indication in the medical practice. In the early 1950s, the patients who survived the acute polio illness, but left with chronic respiratory failure requiring mechanical ventilation, were sent home at that time under negative pressure ventilation and kept in these iron lungs for years. As to year 2014, there are still patients, about 6 to 8 patients in the United States under these iron lungs. The impetus, الدافع for this transfer from the hospital to the home at that time was to improve the quality of life of the patients. Then, by the year 1947, and with the advent of positive pressure ventilation, the interest was shifted to positive pressure ventilation, but at that time it was invasively through the tracheostomy tube. And the need for that at that time also was to resuscitate patients and take of polio, but at the Europe in Copenhagen, then continued to be the method of choice for home mechanical ventilation for patients with neuromuscular diseases. By the mid-1980s, came to the surface and the interest the non-invasive ventilation by positive pressure ventilation, or what's referred to as the mask ventilation. And since that time, that was the method of choice for continuous mechanical ventilation at home. Several factors contributed to the marked rise in the prescription of mechanical ventilation at home. On one hand, is such compact, simple devices with improvement in the technology of the masks and the connections. But there are other factors which pushed the physicians, the healthcare authorities, and the families to choose this type of ventilation and to continue the therapy at home. The increasing costs of care of the patient at the ICU and in the intermediate care, the increasing number of patients who are continued ventilator dependent after recovery from acute respiratory failure, and the scarcity of beds in the ICUs. Together with this, there is an important reason for the increasing prescription in the past 2 decades. The inclusion of 2 major groups, the COPD patient and the obesity hypoventilation patients, to the indications of home mechanical ventilation. If you compare the number of obesity hypoventilation with the obesity epidemic worldwide, and if you compare the number of COPD patients to the previous indication, which are only neuromuscular diseases and kyphoscoliotic patients, there is a big difference, and this made the big gap between the previous indications and the new indications. The target population in the literature are usually and traditionally classified into 4 main groups, and a 5th one I have added because it is under study. And the classification is not only for simplification. The categorization also indicates the prognosis and the impact of the home ventilation on the health of the patient. The first group is that of the impaired respiratory control, either central or as part of the obesity hypoventilation, increasing indications. The restrictive neuromuscular group, the post-polio, was the first to start with, declining now, and spinal cord injury is gaining interest. The restrictive chest wall, kyphoscoliotic are still working, the post-tubercle states are declining now, and the obstructive pulmonary diseases, COPD, is now replacing the other 2 indications. In either group, and in all of them, there are 4 suggested mechanisms for improvement under home mechanical ventilation. Number 1 is to offload the respiratory muscles, whether they are weak since the beginning, as in neuromuscular diseases, or fatigued under the mechanical load. A best example is COPD. And in this way, you recover the respiratory muscles to continue the job in a better state. The third explanation is to improve the sensitivity of the respiratory center to the level of the, or fluctuation in the level of carbon dioxide. And the fourth is to improve the sleep quality. Of the 4 mechanisms, the only consistent finding is that continuation of mechanical ventilation at home do best with improving the chemosensitivity or resetting the chemosensitivity of the respiratory center to the level of the carbon dioxide. Criteria and timing for initiation of home mechanical ventilation, not mechanical ventilation, is crucial. The first scenario, which is most frequently encountered nowadays, is a patient in the intermediate care or in the ICU who fails to be separated from mechanical ventilation, either left with the tracheostomy tube or needs a continuation of non-invasive mask ventilation. Or this type of patient, which is referred as the revolving door hypercapnic respiratory expiration. This patient was repeated, frequent readmissions because of hypercapnic respiratory disease. The second scenario usually starts at home or in the clinic when the patient with restrictive disease, either chest wall disease or neuromuscular disease, and in this case, the patient should become symptomatic. Symptomatic either with breathlessness or signs of or symptoms of nocturnal hypoventilation. Usually at that time, the patient has declining in the mean maximum inspiratory pressure to be less than 60, and in the forced vital capacity less than 50. You do a nocturnal oximetry and you find that the patient is desaturating significantly, less than 88 for more than periods of 5 minutes, and you may measure the daytime carbon dioxide, and the threshold level is 45. In either case, the patient should be stable. Stable upon discharge from the intermediate care, but he is not in need for hemodynamic support. He is not in need for frequent than usual monitoring of some hemodynamic and mental parameters. And in the cold case, you initiate the mechanical ventilation when the patient becomes symptomatic with signs of nocturnal hypoventilation. In this group of patients, we should not wait till daytime hypercapnia. If you wait to daytime hypercapnia, the patient in a late stage of the original disease, and he will not benefit from our therapy. Again, the patient here will be stable, not with current fever, not with current infection. The third scenario is this patient with COPD and or obstructive obesity hypoventilation syndrome, and I wrote them together because usually the indication of home mechanical ventilation are for those patients with a combination of the two, plus or minus obstructive sleep apnea. Again, the patient should be symptomatic with signs suggestive of nocturnal hypoventilation or increasing breathlessness. The threshold for the daytime carbon dioxide is higher from the other group, 55, it is acceptable, more than 55, or a borderline, but there is significant nocturnal desaturation. Again, less than 88% for more than 5 minutes for a period. And in this case, note that it is under 2 liters of oxygen. He is desaturating despite having nocturnal oxygen therapy. The patient who is most benefit, who is likely to benefit from continuation of mechanical ventilation or initiation of mechanical ventilation at home is typically the more hypercapnic patient, the more with hypercapnic exacerbations, and the one with the triad of obesity, hypoventilation, and obstructive sleep apnea. If the physician decides that his patient is in need to continue or to initiate mechanical ventilation at home, and the family and the patient agree for such, either you convince them or they are motivated since the start, the next question is to choose the ventilator. The first question, invasive versus non-invasive. Several factors will help to give the decision. Of these, the most important is, does the patient has the capability to clear the airways efficiently or not? Number 2, does the patient have significant bulbar dysfunction or not? If you don't, so you have the choice. It depends later on. Number 1, the ventilatory needs of the patient. Does he need high pressure or no? And on the other hand, the capabilities of the machines available in your market. Because your market may be different from other markets in other areas where these recommendations are given. After you choose the type of ventilation between invasive and non-invasive, then you will choose the mode. Actually, the modes are limited. If you are choosing the non-invasive positive pressure ventilation, most of the machines available provide you with pressure support. It is spontaneously triggered and supported by the machine, inspiratory and